Hi, good evening, everybody, and welcome back to our webinar 2024. This is our very first webinar, and of course, we would like to welcome Dr. Felix. Dr. Felix has given us quite a
Thank you.
number of spot diagnosis in dermatology series, but we haven't had one for a long time, yeah? Because my schedules are always packed now. So so we couldn't slot you in. And you know, we're so popular now. Jay Chow also is watching us. Anyway, we will start. And if you're a nurse, please go to the Facebook live, watch it live from there. We will send you the registration form. And I think without further ado, we start now because we always have a lot of cases to present. Okay, Felix?
Can you see my slides?
Yeah, can.
Can, okay. So case number 1, you see this patient, he has multiple small little lesions on the palms and the soles, a bit on the arms, a bit on the legs. What do you think he has? He has fever, and he has this for the past 2 to 3 days.
Wow, Kamlin Tan is very syphilis, secondary syphilis. Is syphilis still common now these days?
Yeah, very getting more and more because of the HIV, because of the MSM population, men sex with men population.
I see. Okay. So we have anyone else with anything else? Secondary syphilis.
Bit painful, a bit painful, unable to walk properly. That's why he's in the hospital bed. Can you see the hospital
I want to say
bed?
vasculitis.
Okay.
Anyone else?
Similar lesion on the soles. Where else do you want to examine?
Oh, where else? I'm too shy to say. Okay, come on. Oral. Oh, really? Say oral.
Genital area don't have.
Oral. She said wants to the oral cavity. She wants
Got
to
ulcer.
examine.
Got ulcer.
Got ulcer.
Oral cavity got ulcer.
Okay, Queenie. Oh, Hadri said hand, foot, mouth disease. But this is old person, right?
He is a 55-year-old man.
Oh, scabies, I'm sure it's not. Okay, Wawa Rosalie said wants to examine the
I
eyes.
give you some more clue, Anat.
Yes.
You ask. He tell you that my daughter and my son also have a similar lesion 2 weeks ago.
Oh, so it's hand, foot, mouth disease.
It's
Wow.
hand, foot, mouth in an adult. Looks
An
like
adult.
vasculitis, right? Hand, foot,
Oh,
mouth in adult always looks like vasculitis.
you can get hand, foot, mouth disease in adult also.
Can. I have admitted a few patients because they are unable to eat and they are unable to walk because it's too painful.
And what's the virus behind this hand, foot, mouth disease?
In West Malaysia, most of the time it's Coxsackie, but in Sarawak, it will be enterovirus 71. But if you get enterovirus 71, then you have to be careful because in children with enterovirus 71, you are more likely to get all these myocarditis and they will die because of arrhythmia and heart failure. So you have to give them IVIG as soon as possible.
Oh, I thought it's a very common non-life threatening kind of illness that always happens in school kids.
Except the enterovirus 71 that happens in Sarawak, I think back in 2007, 2008 kind of thing, there a lot of children died because of myocarditis.
Oh, and of course the outcome is good for adults also.
Adult can get it, but adult rarely gets it because adult probably is they are more immunized to it, but you can still see a lot of adults having it. I've seen a few already. I've admitted a few patients, and then it's all confirmed via PCR test lah.
And Kamlin Tan asked, do you routinely test for enterovirus 71?
Now we send off to IMR. Most of the time it comes back as a Coxsackie virus lah.
I see. Okay, if you are a nurse, please watch from the Facebook page. And if your friends are trying to come in, if they are doctors, please watch on the Facebook page too, because we are full already. Okay, so we go on.
Okay, case number 2. This
Okay.
is very interesting. This is
Oh,
genital area, unfortunately. Sorry, it's an
okay.
elephant looking at you. This is an Indian boy who comes to me. The father say, you can see the orange thing on the penis and on the groin, on the pubic area, right? This thing,
Yes, yes,
this orange thing. Can you
yes,
see this orange discoloration? This
yes,
orange discoloration.
yes.
Father say it has been there for the last 1 week. And it stains the undergarment and it stains the diapers. And when I rub it off with water, I really can rub off with water. What do you think this is? Yeah, orange discoloration occurs spontaneously without doing anything. And the parents is complaining has been there for 1 week.
And it's not painful, nothing.
No pain, nothing. But the child say urination a bit painful. Not on any medication yet. Urine a bit painful.
Okay.
So the first time I see this, I say, wow, this Mother Mary got tears that is blood, man. So this one come up here. Yeah, genital area.
Okay, come. Anyone? Funny, that is the color comes out only. Staphylococcus skin infection, child's age. How is the child's? Dr. Suta asked.
The child is 6 years old. 6 years old. 6 years old.
Erysipelas. Erysipelas, Asma Riza said.
Anything else?
Anything else?
Just yellow color. I can wipe it off one. I can wipe it off. No problem. I
Induced
can use water to wipe
discoloration.
off and then you'll come back again.
Okay, child playing with coloring. No, child playing
Cannot
with
be child playing with coloring for 1 week lah. Tak
Yeah,
boleh
that's
lah.
right. That's right. Okay, anyone?
Supernatural.
Food induced. Food induced.
Food induced. Can be. Can be. Anything else?
Tinea. Winnie said tinea.
Tinea cannot wipe off. This one you can wipe off one. Wipe off, come back again. Wipe off, come back again. That's what the father say. I cuci, tak ada, nanti datang balik.
Diaper. Okay, wait. Don't simply guess, Must make sense, okay? This is not a guessing. Crystallized from the urine.
Urine is not this color. Urine is clear like urine color lah, like tea color.
Okay.
Hmm.
Okay. So what is it?
Okay. This is chrome hydrosis. Discoloration of the sweat.
But why only in this area?
Okay. Most common cause of chrome hydrosis is due to medication. The most common medication that give you this color in the sweat is rifampicin. But the child is not on rifampicin.
Okay.
The child is not on rifampicin. This is due to infection. Certain infection, urinary tract infection, it can cause this color.
Oh, I see.
So you need to rule out, and then this patient, this child actually has paraphimosis. So I referred to the pediatrician lah. The time I'm referred to them, they refer to the ped surgeon for circumcision lah.
But so the infection is the reason
The infection is the trigger to cause this discoloration. Usually discoloration is either due to infection or is due to medication. Of course, there are reports. I've gone through a few. The reports are idiopathic lah. They don't know, and almost always orange color. I don't know. The report comes out also a few reports from India. So I'm not sure whether Indians are more likely to get this lah. But there are reports coming out from other races. But the few report I see like idiopathic is from journal from India lah. So I'm not sure whether it's racially predisposed or not lah.
I see. So, and every time you wipe out, it will go clean completely.
Yeah. I wipe again. I don't believe the father, so I wipe. Then after that, a while later, it will come back.
Oh,
So
this
it's
is
the
very
sweat lah.
interesting.
It comes out from the sweat gland.
Okay, next case.
I was totally like, wow, what is this? So interesting one.
Yes,
Like miracle like that.
miracle. Yes, yes. Okay,
Okay.
next
So
case.
this is like interesting case lah. I know it's very, very difficult to diagnose. I also don't know until I go and read up about chrome hydrosis.
Okay, so the problem is again.
Infection. Once the infection settles, the thing goes off lah.
Okay, the problem now is that you need to take this off. Okay. Take this video off because again, when you have this type of videos, my Facebook get blocked.
Oh, okay, sorry.
No, it's not your fault. So my Facebook has already been blocked, so I'm trying again. Who is speaking there? Can you please silent it, please? Okay, now let's continue. Hold on.
Can we continue?
Yes, we can continue. I need to silent people.
Okay.
Okay.
This patient just came to me. You see the nails? I use a dermatoscope for this nail. You can see there's redness of the nail here. There is dilated blood vessel here, and the cuticle doesn't look good. So what do you think is this nail? What is the diagnosis?
Huh?
Looking at this nail, you can get a diagnosis. So all differential diagnosis. Can you give me a differential diagnosis when looking just at this nail? Probably this one needs those who have a bit of dermatology, rheumatology, internal medicine training kind of thing. Don't only you will know lah.
Okay, anyone? Infective, what is that?
Infective endocarditis?
Infective endocarditis, paronychia.
No. Paronychia, nope. It's not painful. It's not painful at all. The presentation is elsewhere. The presentation, the patient has rash on the face, rash on the neck, rash on the chest, rash on the back, rash on the arms. But I just showing what we see in the nails. He has rash elsewhere. What do you think the diagnosis is?
Okay.
A bit difficult, this one.
Hold on. Okay, anyone?
Okay, Queenie said the scleroderma, dermatomyositis, CTD. Wawa Rosli say RA. Suta say IDA, I guess is iron deficiency anemia. Anything else? Somebody say onycholysis. Somebody say paronychia, vasculitis, infective
Psoriasis, somebody said
endocarditis.
psoriasis. What is IDA?
Psoriasis. Iron deficiency anemia.
Oh, I see.
Okay. I give you the answer lah. Queenie is correct lah. Queenie is correct.
Queenie
So
is
when you
always
look
correct.
at this,
Queenie said what? Queenie said scleroderma?
connective tissue disease lah. My daughter can remember Queenie.
Queenie? She can remember Queenie?
Yeah. She say the auntie tonight is the Queenie.
Betty, yeah.
She knows Matty, she can remember Queenie. Okay, when you look at this, it's red and there is telangiectasia. And then when you look at the cuticle, it's ragged cuticle. So subungual telangiectated cuticle equals connective tissue disease. It can be any connective tissue disease. And in this case, when we did the ANA is positive, double-stranded DNA is negative, but here her anti-Rho and anti-La is positive. So this is a 70-year-old lady. Her CEA is slightly elevated. I sent her to the gastroenterologist, just scope today. There is just polyp, but I suspect there is underlying malignancy. So this patient has features suggestive of dermatomyositis. She also got lymph node on the neck. I'm sending her to do a lymph node biopsy tomorrow, and also to look at the fossa of Rosenmuller to rule out MPC. Anytime you see connective tissue disease in an elderly, rule out in underlying malignancy first. That is very, very important.
How old is she?
Almost 70 years old.
Oh, I see.
You don't get a SLE, you don't get a connective tissue disease in a 70-year-old that easily.
Okay, I'm having a little bit of problem. Okay, go on, go on.
Okay, sorry.
No, it's not your fault. I'm not sure whether my video is playing or not.
Okay.
Okay, you go on first,
This is an Indian man. He comes to me with this kind of vision. Seen multiple doctors say not getting better. So what do you think this patient has?
One, psoriasis. Okay.
Okay, anything else?
Anyone else? Okay.
He has it on the face. He has it on the body. You can see some on the body. He has it on the upper limb, the arms as well. Wawa Rosli said discoid lupus. Anything else?
Oh, possible, yeah, possible discoid lupus. But discoid lupus usually more round and over the hand, I think. Sensation intact? Sensation intact? That's a question.
The sensation is intact. The sensation is intact. Yes, the sensation is intact. No problem with the sensation. He also has this some of this lesion on the scalp.
Ray Ong in Facebook said discoid SLE. Oh, Ray Ong, I thought he's a cardiologist, also can do. Okay, go on. Okay, now I cannot allow pictures of anything because a lot of things because Facebook will always block me now. Ah, susah. Teaching also susah. Okay, anyone else? Okay, seborrheic dermatitis. Navina says synovitis acne. Synovitis acne. Wow, this one all. Queenie said discoid lupus. Cutaneous discoid lupus. Same like Ray Ong. Okay.
Wawa Rosli also said discoid lupus.
So is discoid lupus?
Yeah, it's discoid lupus. You look at this one is scarring lesion is discoid lupus. It's discoid lupus. Discoid lupus, what we do is, number one, most of the time you need a biopsy to confirm. You do a biopsy, you take the skin lesion, and then you can see the feature typical of discoid lupus. There will be lichenoid dermatitis, and then you send for HPE with immunofluorescence. If you are lucky, then you can see the granular pattern on the basement membrane zone. You need to do your normal SLE screening, but discoid lupus is kind of chronic cutaneous lupus. Most of the time, they don't progress to SLE. Only around like 5% to 10% progress to SLE. But around 40% of patients with SLE do have manifestation of discoid lupus.
Oh, I see.
So, yeah.
But isn't his gender and his race against?
Yeah. But discoid lupus can affect male. Proportion of male and female is almost equal in discoid lupus, but it will be 9-1 in systemic lupus.
Oh. So
And discoid lupus
the
always
treatment,
present
is
to
it
the
topical
dermatologist.
or is it the oral steroid?
Because this is very, very disabling because of the nature of the disease. It's called scarring. We need to give very strong topical steroids.
Oral steroids won't work?
Oral steroid, yes. You can give oral steroid. I gave this patient oral steroids for a short period of time, and then I put him on biologics lah.
Oh, I see.
And you have to give them hydroxychloroquine as well, and advise them to stop smoking and also to avoid sun exposure, because sun exposure makes it worse.
And why smoking?
Oh, smoking can make this one worse. And then with hydroxychloroquine, if you give hydroxychloroquine with smoking, the effect of hydroxychloroquine will be attenuated.
Oh, I see. Oh, that's interesting. Okay, next.
So you have to ask them to stop smoking lah. But he smoked crack lah. This guy.
Smoke crack. Crack as
Used
in
to, used to.
crack as in the drugs.
Yes.
Oh, I see. Okay.
Used to, because he lived in US before, and yeah. All right.
Okay.
Next is sorry. All right. This patient comes to me because he's very unhappy with this rash. Totally asymptomatic, no itchiness, nothing. Got a lot of redness and a lot of pigmentation. Can you see pigmentation here, pigmentation here? Really unhappy with this. What's the diagnosis? On both legs.
Anyone?
Not itchy, not painful.
I think it's
Red rash.
eczema.
Okay. Not itchy, not painful, eczema.
Okay.
Anything
Okay.
else?
I changed my mind because it's not itchy. Okay, anyone?
When there's no answer means it's very
Okay,
difficult already. Nobody knows.
Mr. Heng, yeah, if Queenie never answer means, okay, Ong said contact dermatitis, Queenie says stasis eczema, Wong said, Mr. Dr. Chan said worm infestation from where walking barefoot on the beach. Oh,
Telangiectasia, vasculitis. Anything else?
anything else?
Everything
Vasculitis.
incorrect.
Okay, I think vasculitis is not.
Everything incorrect. Anything
Everything
else?
incorrect. Even Queenie also incorrect.
Try again.
Let me see.
Vasculitis is the nearest, but it's still incorrect.
Vasculitis is the nearest.
That's still incorrect. Related to coagulation or some storage disease, also not
Storage
related to
disease.
coagulation. Everything is normal, no storage disease, nothing.
Wow. Right.
Some more. This is a very benign condition lah. It's just like dermatologist likes names, benign
Okay,
condition.
Wawa Rosely said miliaria.
Miliaria. No, not miliaria. No miliaria.
What is miliaria? Lupus
Miliaria
vasculitis.
is block sweat glands.
Oh.
Lupus vasculitis, also not vasculitis, not vasculitis. Angioma, not angioma. Seborrheic eczema, not seborrheic eczema. It's not eczema at all.
Okay.
Unilateral region, no, both the legs, purpura,
Okay.
you're almost there. Dry skin patches, you're
Oh,
not
Ray
there.
Ong said Hanok HS.
Shoreline purpura. No, not shoreline purpura. Hemosiderin, You can consider it's due to hemosiderin infiltrates, but is small part of it. ITP is not correct.
Okay, give us the answer lah.
This is capillaritis. Your capillary pecah, capillaritis. So this is not vasculitis. This is capillaritis. This is a condition called pigmented purpuric dermatosis.
Pigmented.
It comes on suddenly one. Most of the time it's idiopathic, but sometimes it can be associated with certain drugs given to the patient.
So, okay, hold on. Give me the title again. Pigmented.
Pigmented purpuric dermatosis. So you can see all these small little dots are purpura, which a lot of you say purpura. But when you look at purpura, due to vasculitis, it will be purple, it will be bigger. This one is what we call as like pepper, salt and pepper, like cayenne pepper appearance, small little dots.
Yes, yes, yes.
Okay, and then when it heals with pigmentation. Can you see the pigmentation?
Yes.
It heals with pigmentation. So it's pigmented purpuric dermatosis is part and parcel of capillaritis. So sometimes some people get it because of standing too long, over exercise. Most time is idiopathic. Sometimes can be related to drugs, certain drugs that was given to the patient. But most of the time it's idiopathic. No need to do anything with it. Usually we'll just put a bit of steroid cream. You self-resolve. Most patients will self-resolve within a few months, but some patients will get on and off for the next few years.
Oh, I
The
see.
reason I put it, yeah, the reason I put this up is as a differential diagnosis to like things like vasculitis and eczema, because this one is not itchy, not painful, and no harm to the body.
So no need to treat.
You can actually leave it, no need to treat. But when patient comes to me, means they are not happy lah, then I'll give them some steroid cream as a form of treatment.
Or steroid cream.
Yeah.
Okay.
Right? It's
And
very benign. Very benign.
And then pigmentation, will it go away?
The pigmentation, once everything goes off, there is no more capillaritis, the pigmentation will resolve by itself. All right. So next one, it will be, okay. All right. This patient presents with a lump on the scalp. Purplish in color. What do you think is the possibility?
Okay. Well, this one, Ray Ong, are very active here. I must see what he says. Okay, who else? Come on. Purplish. Okay, Christine Saw said basal cell carcinoma.
Okay.
Okay.
Anything else?
Basal cell carcinoma.
Oh, just now, for the pigmented purpuric dermatosis, we need ask treatment. It's just symptomatic treatment only lah.
Yeah, you also mentioned steroid cream.
Yeah.
Nana Kim
abscess,
said
PPC.
scalp abscess, angioma.
Salah.
No.
Kumuta. Yes, angioma. What type of angioma?
Angioma.
Which color? Angioma, you are right, is angioma. Angioma means abnormality to the blood vessel.
Okay. Berry angioma. Dr. Key said berry angioma.
Okay. Anything else?
Suta said
Any
cherry
other
angioma.
offer?
Hey, you
Oh,
guys
berry
making me
angioma.
hungry lah. One berry.
Berry angioma.
I feel like eating.
Can I add one more watermelon angioma?
Okay, Wawa Rosalie said keratoangioma and Kumar said hemangioma.
Hemangioma. Okay, what else?
Wow, there's so many angioma. One. James said hemangioma.
Right.
Okay, in Facebook, Yip Mi Ching says scalp angioma. She also so that what kind of angioma is this? That's what Dr. Felix is trying to ask. It is
I agree
angioma.
with them now. All angioma because you can see all the blood vessel. It's all angioma.
Hello.
She
Auntie
said hello,
White
Dr.
cake
Becker.
gitu. Oh, auntie.
So this patient has angioma, you are right, and this patient has angiosarcoma.
Oh my God. The
Yeah,
word.
so it's a malignancy lah. It's a malignant angioma. I
Oh,
think angioma is okay. When you see anything that is purplish, think about blood vessel. And when you see purplish like this, think blood vessel, you have to think about malignancy lah. Unfortunately, this patient is very, very young. Usually we see angiosarcoma in an old individual. This patient is very, very young. This patient is in her 30s only. So it's angiosarcoma.
and what is the difference between other angiomas? For example, you say what kind of angioma? Is there
You,
berry? Is there really berry and that's really
no,
cherry?
it's cherry angioma lah. Cherry angioma, hemangioma, all usually you see when in childhood.
I see.
They come out very early in life. This one comes out very, very late in life. So when you look at new onset angioma, most of the time you have to think about whether it's malignancy or not lah.
Okay,
This
just
patient has no other comorbidities. I'm
okay.
not sure whether oh, this patient already of chemotherapy. That's why he has no hair and gray hair lah. The chemotherapy is for her angiosarcoma. This is just one new angiosarcoma that pops up lah.
Oh, she already diagnosed. So now this is a
Yeah, she
new one.
already diagnosed. This is the new one. She already
Oh,
diagnosed to have angiosarcoma. And
1000.
in elderly, sometimes your angiosarcoma can be very slow progress. I have one patient that seen me 5 years after the progress because tissue
Sorry. Hello? Ayo, must be mine lah.
yeah. But angiosarcoma, you have to be very careful because when you biopsy, you bleed a lot one.
Oh,
Yeah.
okay, we go on. Can you hear me?
All right.
Okay. Okay.
Can. Another nodule. This is a 2-year-old kid presented with this nodule on the thigh, back of the thigh. What do you think?
I
Need to do anything or not?
no
Need
need.
to cut or not?
No need.
No need. Then what is it? The parents say, hey,
Okay. Let me
can you
try.
spread to other people or not?
Cherry angioma. Cherry angioma.
No lah. It doesn't look like angioma. Oh, this one.
Okay.
Purple color, like skin
Okay.
color.
We'll try. Okay. Come on. Anyone? Anyone? Okay. Somebody say a pyogenic granuloma. Doctor.
Okay, pyogenic granule. It's
Okay.
not bleeding. It's not bleeding. Sorry. It's not bleeding.
Oi.
Molluscum, okay.
Molluscum. Okay.
All right, molluscum possible, but there is no umbilication.
Molluscum
Anything else?
contagiosum. Oh, wow, this one all.
It comes out
This is a very common
just
thing,
one
right?
dot only. Just one dot only. Not nowhere else.
Now they've got 2 kids with you.
Not painful,
Okay,
asymptomatic.
Brahman,
Parents
Kim
worry
Mei
only.
Chin say lipoma, but I don't think it's lipoma. Lipoma doesn't look like that. No, it's not scar. Is
Lipoma
it
is
scar?
deep inside. Deep inside. This is superficial.
Okay,
This is superficial.
Chen Ziki say capillary hemangioma. Okay, let me see.
No blood vessel component there.
Oh, no keloid. Not keloid. Definitely not keloid. That one. Okay, Queenie said
No
juvenile.
injury there. It's a 2-year-old girl. Very unlikely keloid lah.
Queenie said juvenile
No injection there also.
xanthogranuloma. Oh.
Yeah, it's juvenile xanthogranuloma lah. Queenie is right. Juvenile xanthogranuloma. So this is juvenile xanthogranuloma. It's a type of histiocytoma. No need to do anything. I reassure the parents. Just leave it, and usually it will clear off by itself.
Okay. Oh, so what is the thing behind it? Does it come suddenly or
It's
born
just
with it?
usually it's just accumulation of histiocytic cells in the body. Most of the time, a solitary xanthogranuloma, just leave it, nothing will happen. It's a self-resolving condition lah.
Oh,
But
so
if parents are really worried, sometimes we cut it out for them lah. But most of the time, no need to do anything. Right? It's self-resolving for the over the next few.
okay.
You
Ayo, my Wi-Fi. Okay. So
right.
so this is
This man.
Can you hear me?
So this man presented to me. Yes.
Okay.
So this man presented to me with this type of hyperpigmented lesion, mild itchy. Mild itchy, you can see it on his neck, you can see it on his face, especially the jaw area, the cheek area, and the forehead. A bit worried about this pigmentation. Any possible cause for this pigmentation?
It looks like ecchymosis.
Nope, no ecchymosis. No injury there. Slightly itchy.
Tinea nigra. Tinea nigra.
Nope.
Tinea barbae. Oh, yo.
Not tinea.
Not tinea.
Not
Photo.
tinea. Photosensitive. Okay. Occur on a photosensitive area. You are right, but it's not dermatitis. This is not dermatitis. Anything else?
Oh,
It's an Indian man. You see the color, Indian man.
oh, because it's photosensitive means because it's where the neck, where it's not covered by the clothes.
Yes. That's why you can say it's photosensitive. But this is not dermatitis. Photosensitivity can be dermatitis. Melanoma, no melanoma. No
Lemon,
feature to suggest melanoma.
somebody,
Post-inflammatory, maybe is post-inflammatory. There is a possibility it's post-inflammatory.
somebody said
Histoplasmosis, no.
somebody said dermatomyositis.
Nope. Doesn't look like dermatomyositis. Dermatomyositis usually is red rather than pigmented.
Okay, we wait for Queenie. Okay, melasma.
Melasma usually not
The
on the
face,
neck, but
Mm.
can get, but it's not likely to get on the neck lah.
Because I know melasma very well. Melasma and I
Ah,
are very close.
yeah, melasma is usually on the cheek rather than prurigo nodularis is usually a nodule and it's very, very itchy. This is not a nodule. It's just porphyria. Yes, you can get porphyria on this area. You can get porphyria cutaneous tarda on the sun-exposed area. But porphyria cutaneous tarda is not common here. And porphyria cutaneous tarda usually presents with like burn-like lesion. This is like not burn-like lesion. Okay, you want me
Okay.
to review the answer?
Yes, please.
Lichen planus pigmentosus.
Lichen planus.
Lichen planus pigmentosus. Lichen planus is common in the Indian community. I see most of my patients with lichen planus being Indian. Probably it's genetically determined. The Chinese and the Malays usually get lichen planus due to medication. So lichen planus pigmentosus, especially on the face, can mimic melasma. So treatment of lichen planus is steroids. Okay, either oral steroids or topical steroids. Yeah. So lichen planus pigmentosus is very, very common in Indian population. So because they are Indian, their skin is darker shade. So usually you get lichen planus in a fair actually get the purplish color. Sometimes if they are fairer, we can actually get purplish color. And then we can get reticular hypopigmented lesions on the buccal mucosa as well, which this patient has a bit. I didn't show the buccal mucosa.
Oh,
I
I
don't
see.
want to confuse you.
Okay. So
So
this
it's
one don't need
genetically
treatment.
predetermined one.
This one don't
Treatment
need.
is usually topical steroid, but the buccal mucosa lichen planus we have to monitor it properly because the mucosa lichen planus can progress to develop SCC, squamous cell carcinoma. There's a risk.
And what is the pathology behind this lichen planus?
Okay, so this patient presents with this kind of lesion on
Sorry, no.
SCC for buccal mucosa is because of constant irritation to the buccal mucosa. The
Oh, no,
irritation causes the BPC.
what is
Yep,
the pathology behind lichen planus?
autoimmune.
Oh, autoimmune. Okay, okay.
Mm.
Okay, next.
Full lesions on the uh, toenail lah. All the toenails have lah. Most of the toenail have. Most of the fingernail also have. I just show a picture of one of the feet only lah. All the fingernails, all the toenails looks almost similar. So what do you think this is? Paronychia? Anything else?
Yeah. Oh, somebody say lichen planus in on Facebook.
Excellent.
Niva Sini Muniendi. Oh, excellent. Okay, good. Okay, anyone else for this? Come on. It's only at the
It's part and
side,
parcel of paronychia lah. Paronychia is correct lah. But when you look at this properly, what do you think? This thing,
Only at the
this
side.
thing, yeah, only on this side. And then you can see it's swollen. It's
Oh,
paronychia lah. Swollen is paronychia. But this
no, I don't know.
a bit of bleeding here.
Wait, my Wi-Fi again go crazy. Okay, what is it? Can you hear me? And
Yeah.
okay,
Yeah.
okay, go on. So what is the cause of the paronychia?
So what do you think this patient has?
What do you think
This patient a bit special lah. This patient is given this one is paronychia, you are right. But what are the small things here? What do you think are these small things here? Pus. Yes, there's a bit of pus and also bleeding.
Yes, true. Bleeding, yes. Hypergranulation.
Hypergranulation. Okay.
Okay.
Yes, this is a granuloma. And when you have pus and granuloma, this is pyogenic granuloma. So this patient has pyogenic granuloma everywhere on the toenails and the fingernails. This patient is
God, the Facebook Sumitra got it. Paronychia with pyogenic granuloma. Oh, great. In Facebook, a lot of doctors are very active there. Okay.
Yeah, lung CA.
Oh, it's related to
The
carcinoma? Sorry, this. Can you wait? Hold on. Can you hear me now?
Yeah, sure.
Sorry,
Yep.
FELIX. Is it related to the lung cancer?
Yeah. I can hear you. No, it's related to the chemotherapy.
Oh, it's related to the chemotherapy. So, I've seen this before. There is a lung cancer drug that is under trial, and I've seen a patient with this chemo. I don't know what chemo it is. Not similar, but all the nails had this kind of paronychia, but no pus.
Yep.
Pyogenic granuloma. Okay.
First steroid tak jalan. The only way that jalan is stop the chemotherapy. So the trial doctors reduce the dose of the chemotherapy and stop it for a while. Things gets better lah. But because she is in a trial, so you cannot stop for too long.
Oh, so it's
Clinical
the same
trial.
drug. It's the same drug that my patient
Yeah.
had.
Yeah.
Because they need
Not
to
bad.
do echo or something like that.
Yep.
So it's
Probably the same
drug.
patient lah.
Not
Probably the
same
same
patient.
patient.
No. Mine is a Malay lady.
Oh,
Yes.
okay.
And then they
Yep.
also had to reduce the dose. But she didn't
Right.
pass. But she was very
Yep.
painful. It was
I have
very...
another patient in the ward also like that.
Oh, but it's a trial drug. I remember now.
It's a trial drug. It's a trial drug. When it's a trial drug, it's very difficult because whenever we need to give medication, we need to check whether we can give the medication or not because all these clinical trials are very strict.
Oh. Yes, the clinical trials, but I think she stopped for a while because it was too...
Yeah. And this patient not only have this patient also has very severe seborrheic dermatitis due to the chemotherapy.
Okay. To all the nurses and to the doctors, we will share the what soon, yeah? Okay, go
So
on.
this patient has this kind of lesion. You can see this kind of lesion for the past 8 years. For the past 8 years. 8 years already have this kind of lesion on the right arm. He is he's involved in a business where they do gardening and open a petting zoo. So they are in frequent contact with soil. So what do you think this patient has?
Petting zoo, where is this?
Yeah. There are somewhere in KL lah. It's a petting zoo business, plantation, some soil business, contact dermatitis. Anything else that you think? Already 8 years are not getting better at all.
Dr. Key say Majoji granuloma. Wow, too fancy.
Majochi granuloma, okay, due to fungus. Anything else?
Let me see Facebook.
Deep fungal infection, okay. Deep fungal infection, very good. Anything
So
else?
Sumitra says sporotrichosis, and Vincent also says spirotrichosis, and Ray Ong, the cardiologist who wants to be a dermatologist, says no, and then he deleted. Okay, go on.
Anything else?
Anything else?
Chemical related? Nope, not chemical related. Okay, the nearest is sporotrichosis and deep fungal infection. Any other deep fungal infection that you know of? Animal tinea? Nope, it's not animal tinea. I can tell you that this is soil-related tinea.
Oh, I see.
Soil-related fungus. So anything else that you think what are your diagnosis? Blastomycosis. Dr. Key, you are very right. What is in front of blastomycosis? There's a name in front of blastomycosis. Then you get the diagnosis already.
Blastomycosis.
Blastomycosis is the name at the back. There's a name in front.
Okay.
Okay. Not
Cos-
coccidioblastomycosis, is chromoblastomycosis.
Oh,
Chromoblastomycosis is due to a black fungus usually found in the soil. So this one is very, very common in patients who do activity with soil and also rotten wood. Because you do timber industry, some of the time the wood is rotten. So the fungus grow on all these rotten woods. And then once you have an injury there, you go in. So this chromoblastomycosis is very you cause a lot of problem now. It's very, very prolonged. So if you don't treat it over a prolonged period of time, because of the constant injury to the skin, it will progress to develop squamous cell carcinoma. So you have to treat this patient once you see it, and you need to treat this patient with, usually what I do is I treat with combination of 2 antifungal, itraconazole together with terbinafine, and usually I'll do cryotherapy to the lesions.
Oh, cryotherapy.
Yeah, you have to, and then you have to do many months until it clears. So the duration of treatment range between 1 year up to 8 years to 9 years.
Oh,
Very difficult to clear. Very difficult to clear. Unless you have one lesion, then probably you cut it out, then it will clear. Otherwise, it will be very difficult to clear.
I see. Okay. Now we do 1 or 2 more. We can.
Okay. All right. This lesion, patient presented with this lesion on the thigh. Come to me with this lesion on the thigh. What do you think?
I always watch on YouTube, not YouTube. They always take it out one.
Dr. Pimple Popper.
Something like that. They can take it out, the whole thing.
What do you think it is?
Oh yeah, that one is
Betty
video.
is very good. Betty will know the diagnosis.
I don't know the diagnosis. I only know the video. Okay, let me see. Ingrown hair. Somebody said ingrown hair. No, it's not ingrown hair. I know it's not ingrown hair. I used to
It's
know.
on the thigh. It's on the thigh. It's quite
I
big one.
used to know the diagnosis because I go and check it out. Comodion. Wawas Rosalie said, and then Christine said blackhead. No, it's not as simple as blackhead. It's Carol. Ayo, I don't know lah. Last time I heard blackhead acne. No. Okay. Yes, the dilated thing. Somebody said something dilated. Dilated pore, whiner. Is it dilated pore, whiner?
It's epidermolysis lah.
Alamak. But this dilated pore, that whiner
Yeah,
is.
it's a pimple popper Tyler.
It's a
Yeah, it's
pimple.
nice. I just take the black thing out, and then we squeeze everything. Everything came out together with the sac of the epidermolysis. Very nice, very nice, very nice.
Oh, you should
If I
take
have a video, I think everybody will enjoy the video lah.
I used to scold my daughters for watching this. I said, so disgusting, so disgusting. Then after a while, I watched.
But very therapeutic one, no?
Yes. After a while, I was stressed. I started watching. I was like, wow, this one really can relieve stress, huh?
It's very nice to do lah. It's very nice to do. Very very
Rewarding, very
like there is a
rewarding.
sense of success.
Yes, satisfaction. Okay, so this is different from the pot or whiner lah. What dilated?
I think probably almost the same thing lah.
Almost the same thing. Okay.
Okay, this one a bit difficult unless you are interested in hair lah. So this is I think 80 plus year old lady who comes to me with hair loss, not happy with the hair loss. You can see that the hair loss is not mainly on the you do have a bit of hair loss on the parting area, crown area, a bit of hair loss, but you can see a lot of hair loss on the frontal area. You can see the front is almost gone. The front is almost gone. So for those who wants to are interested in hair, what do you think this lady has? Female pattern baldness, yes, but he do have a bit of female pattern baldness here. You can see that there is a hair loss around on the parting area, but the man hair loss is around here, in front.
Okay,
And
Queenie,
then you can see small little dots, here. Anything else besides female pattern baldness? I think this is a bit difficult, but if you are not really into hair lah.
But there are a lot of, I think, people who know dermatology here. So, anyone?
Pidra, no Pidra. Not Pidra, not fungal infection. I think this is a bit difficult. I give you the answer. This is
Okay.
frontal fibrosing alopecia.
Frontal fibrosing.
Frontal fibrosing alopecia. So what I did for her is that I give her steroid injection on the frontal area. After 3 to 4 steroid injection, the hair starts to grow lah. Your immune system attacks the hair and cause the frontal area to fall down and cause a bit of scarring. A bit difficult if you are not interested in hair. By right, I should do a biopsy, but the patient is not very keen in biopsy.
Okay, Jennifer asked, is it the same as AGA type 2?
No, it's not IgA. This is totally different. It's a totally different diagnosis. It's immune system related.
Wow. Jenny Ching.
Mhm.
Jenny Ching from Facebook got it right.
Mhm.
She said that it's whatever you say.
FA lah, frontal fibrosing
Yes, frontal
alopecia.
fibrosing alopecia. She got it right.
Yeah.
Somebody else. Okay, so yeah, Jenny Ching got
So
it
I
right.
think I guess if you are interested in hair only, you will know this. If you're not
Oh,
interested,
even
probably you
Vincent
won't know.
Chew also got it right. Wow,
Very good.
Facebook very good lah. Nivasini got it right also. Wow, Facebook doctors better than Zoom.
I think a lot of aesthetic physicians do hair, so probably they'll know a bit about this lah. A lot of aesthetic physicians do hair. So
Yeah,
you need steroids lah, this one.
oh, okay. So,
Okay, done.
thank you very much. We'll bring
Yeah.
Dr. Felix Yap back again sometime this year for sure. It's always been great to have him. Okay, so I'll stop recording.